Each year, Microsoft Research hosts hundreds of influential speakers from around the world, including leading scientists, renowned experts in technology, book authors, and leading academics, and makes videos of these lectures freely available.
So we're very happy to have today Mark Terezi speaking. Mark is a professor of computer science at Johns Hopkins. He works in NLP and machine learning, and in particular, some of the methods he uses are graphical models. He works on information extraction, and one of the application areas he's got into is medical informatics, medical information applications. And I think he's going to talk to us a bit about some of that work. And also, Mark got his PhD at UPenn, and I think he overlapped, and he knows a few of the others.
I do.
Jen and Hannah in particular. So welcome, Mark, and we're really looking forward to your talk.
Thank you so much. So I like to start by figuring out who's in the audience so I can customize a little bit what I say. So I'm going to make some guesses as to what you guys do, and you can raise your hands if I guess correctly. And at the end, you can, if I don't say anything that's relevant to you, at the end, I'll give you a chance to define your own area. So how many people here would call themselves machine learning people? You can raise your hand more than once, by the way. Machine learning, okay. Social science, economics, information retrieval, mobile devices. I just threw that one in there. I don't really know. What else? Systems? No. Okay, did I miss an area? All right, good. Wow, really? And if you're online, I don't know if anyone's watching or they're watching this later, but you can email me if I missed your area. How's that? So mining web data for public health. So what I want to do today is start by telling you a little bit about myself, so you get a sense of where I'm coming from for the rest of the talk. Some of you know me, I know some of you. I see a lot of new faces. So let me just tell you who I am, and I think it will help you understand what I'm going to be talking about. So I work in a couple different areas, machine learning, and I've just listed, I kind of went through recent papers and wrote down things that I've published on recently, just to give you a sense of what I do. So one area is machine learning. The other area I spend a lot of time is natural language processing, the NLP community. And then the area I've really moved into recently is public health, and I'm not listing what those areas are because I'm going to talk about some of them today. And of course, really interesting work happens when you overlap these areas, and so never or rarely am I working in one circle. I'm usually working in two circles at once. Very rarely do we get something in the kind of middle where you get to do all three things at once. So that's who I am, and specifically, I'm a computer scientist. I'm trained, my PhD is in computer science. My undergrad degree is in computer science. I'm in a computer science department, and so that's really a perspective I'm bringing today. So I'm trying to talk to all of you as a computer science scientist who has become interested in public health and trying to convince you why this is an interesting area and why this is something that we as CS people should care about. For those of you who got degrees in other fields, you are computer scientists the rest of today. You work in Microsoft, so I feel like that's a fair generalization to make. Okay, so what I want to say is that we have an opportunity to save lives, all right? And this is not something you hear very often in a CS talk. And that's part of the reason I'm saying that is because I really believe that this is an opportunity that we don't really see very often in a technical field where we can make a difference on the quality of people's lives, but more specifically on actually saving people's lives, right? Extending lives, preventing disease, et cetera. And so what I want to do is back up this dramatic claim by telling you about some examples. First, I'll say why I think this opportunity exists. Then I'm going to give you some examples of work we've been doing at a very high level to give you a flavor of the sorts of things that I think are possible. And then I want to drill down and spend most of the day on one specific example and talk about some of the methods that we've innovated in order to handle these sorts of problems. So today will be some convincing you, some overviewing of work, and then some in-depth machine learning methods. Okay, so I'm interested in this area of public health, which is the prevention of disease, prolonging of life, promotion of health Those all sound like very good things. What does public health actually do? And there's a lot of examples that you guys are probably familiar with that constitute public health. Things like disease surveillance, which is very much in the news at the moment because we're in the middle of a flu epidemic or at the beginning of a flu epidemic. Self-medicating behaviors, vaccines, drug use, tobacco use, medical education. These are all things that public health people think about. And if you were to take a class on public health, you would learn about the public health cycle, which is a 10-stage process. This is not a public health class, so I've boiled it down to a 2-stage process. Okay? And the 2 stages are, we have your doctors, which all of you can be for the sake of this argument, and the population, which you guys are also part of. And the first step of the cycle is surveillance. And what this basically means is doctors want to know things about the population. What's going on? All right? Once they know that, they can come up with interventions, which are policies, ideas, procedures, campaigns that are going to be designed to improve the health of the population. And this is a cycle that you probably see all over the place. If you're in product design and testing, it's a very similar cycle, right? You look at the population, you look at the problem, you understand it, you come up with a solution, you deploy the solution, and then you see, did it make a difference? What are the remaining problems? And you repeat, right? And again, if we were in a public health setting, there's 8 other steps in this cycle I'm not talking about. So the key here is that this requires data. We need data on the population in order to do any of these things. In order to craft any policy, evaluate any policy, we need data to understand what's going on in our population. So I'm particularly interested in the role of web data as a data source for doing this. What do I mean by web data? So I mean very broadly things like social media, search behaviors, web forums, really a large variety of different sorts of data sets that are available online in different ways. Health is a really big part of these data sets, right? If you look at, if you use any of these, you see people talk about health-related topics. There are obviously health-related forums, people do health-related searches. And so to the public health community and trying to learn about a population, these are really good resources for giving us information on that population. And this is where we as computer scientists come in, because we're very familiar with these data sources and how to manipulate these data sources and how to use them to learn various things about our users. And so those same techniques and same ideas are applicable to learning about the health of a population. So probably the best example of this has been the large amount of work on using search or Twitter or Facebook or whatever for disease surveillance, right? And I say it's gotten a lot of attention. There's been a lot of news stories about it. A lot of companies have been started on this idea. And this is great for a number of reasons. We can learn about flu faster using Google, or there was a paper on Yahoo. I don't know if there's been a paper with Bing queries, but there's been one on Baidu. So there's a lot of papers that show this. We can do a better job of measuring flu faster in different areas, et cetera, et cetera. This is great. And this is why it's received a lot of coverage. But I actually think of all the opportunities, this is probably the least beneficial. And it's the least beneficial because what we're doing here is really improving on a technology that already exists by making it a little bit faster, a little bit better, or maybe a little bit cheaper. But where I think the real opportunity for us to focus on is in an area where there is no equivalent data sets, there are no equivalent data sources, and that's really in behavioral medicine. And so I just have to define behavioral medicine. It's becoming obvious why we have an impact here, how people's thoughts and behaviors affect their health, right? That is, again, a very large, broad area. What is behavioral medicine? That seems like a lot of different things. So I'll give you some examples. It's things like obesity, drug use, smoking, vaccines, gun violence, where these are public health topics that are primarily driven by choices people make. Right? Obesity is primarily driven by choices people make about their diet. Smoking is made by people choosing to smoke, right? Vaccines, right? I'm not talking about developing vaccines, I'm talking about people using vaccines. Again, choices that people make whether they do it. And this is behavioral medicine, understanding how these choices that people are making are impacting their health and impacting the health of the population. So how important is behavioral medicine? So it's very sad, but this is a CDC page that's actually bookmarked on my computer because I go to it so often. These are the leading causes of death in the United States. I think these numbers are from 2010, 2011. If you've never seen these numbers before, I'll let you take them in. It shouldn't be anything that surprising. The number one killers in the United States are cancer and heart disease, such that combined, I think they're maybe more equal to everything else on the list combined. Like those are the major killers in the US. But you see other things up here, like diabetes is big, influenza and pneumonia are big, et cetera. Accidents, these are like car accidents, skiing accidents, less so, things like that. So how important is behavioral medicine? So all of these things here have some behavioral component to them. Right? So cancer is tied to lifestyle choices. Heart disease is tied to lifestyle choices. Obesity. Cancer is tied to smoking. Diabetes obviously is tied to lifestyle choices. Intentional self-harm, this is suicide. There's obviously a lot of behavioral component there. So behavioral medicine is really important. If we just look at what kills people in the United States, behavioral medicine has a lot to say about it. And so improvements to what we know about behavioral medicine and know about populations really make a difference in terms of saving lives. So why web data? How does that fit into all this picture? Like, why am I here talking about this? Well, it's because online activities reflect user behavior. And this is obvious. Everyone who works with web data knows this. But what it means is that by using this data, we can learn about behavioral medicine. We can learn about what choices, health choices people are making and how people make these decisions in the population. And the reason I think this is a much better opportunity is we're not replacing something that already exists. You can't really get this information any other way, right? The current best ways to get information in public health is you talk to doctors, you go through medical records, and you call people and do telephone surveys, right? And knowing that, and then thinking about the sort of online trails people leave, those trails are clearly going to contain a lot more information about their health and their health behaviors. So that's really the opportunity here. So what are the core questions in behavioral medicine that we want to answer? And I think these questions are very familiar to people. The first is how people make decisions, right? How do people actually make the health decisions they make? How do they go about that decision process? How do people weigh evidence? This is referencing a study I think a lot of people will recognize. But how do people look at different factors, different pieces of evidence, and consider them? And people don't do this in an impartial way. People have a lot of biases. People treat information differently, weigh it differently. How do people weigh that information in order to reach their decision? How are other people influencing that decision? How do your social circles influence your decision? How do the people you connect with, your family, et cetera, impact the decisions you make? Right? So these are not behavioral medicine questions. These, I think, are general questions we encounter in a lot of the social sciences. Right? But understanding these questions in the context of health is key to understanding behavioral medicine. And that's really why I think we have the opportunity to save lives. Because the data I think that's critical for understanding these issues is data familiar to people in this room. And the sorts of key questions here are the questions that are familiar to people in this room. And they're not methods and they're not ways of doing business that public health researchers typically engage in. Right? And so that's really where I think people like us can come in and actually make a difference. So that's my argument. The rest of today, I will try and give you some evidence for this, if you don't believe me yet. If you're already on the bandwagon, you can wrap up your lunch and go or stay, it's fine. But if you would like to see some evidence, I'm going to split the rest of the day into two sections. I'm going to first give you 3 quick examples of work we've done. And I don't think any of this work has answered any of these fundamental questions, right? It hasn't answered how do people make decisions, right? But what we can do is start to look at some of these factors and start to peel back the layers and get some understanding. And answering these questions is going to look a bit different depending on the health area and application you're looking at. But I want to give you some flavor of the sorts of things we're asking. And the second is I want to look at one in-depth case, which is drug use, and talk about how this is an opportunity for methodological advances, where the sorts of problems that we want to solve are not problems that we necessarily have answers ready to go on our machine learning toolkit shelf or whatever. And so I want to talk about some of the work we've done there on new methods to address some of these problems. Okay, is everyone with me still? Any questions? Okay, no one's asking questions, which I assume everyone loves this.
I like the way that money is always associated with drugs.
So let me just say this. So by drug use, I mean illicit drug use. And you have to find a picture that is showing drugs, but also the illicit nature. So putting money in the picture is usually a really good way of doing that. Just pills don't necessarily do it. Money is like really the tip off that something's wrong. I don't know why, because normal medication costs money too. But that's all the pictures of illicit drugs that tend to have like money in them that I use. Okay. All right. And I try not to have actual pictures of faces of people. So like all my smoking pictures will be like of cigarettes, not like a person smoking. That's also, I don't want to implicate anyone, especially like stock images of people smoking. All right, so let's start with some examples. All right, so the big story a couple years ago, 2008, if you weren't paying attention, was 2008, 2009 was the financial crisis, right? And this was what was driving the news. Right? This was driving what everyone's focused on. And of course, this is going to show up in health, right? Because there's a question or a theory that the financial status of an individual has an impact on their health, right? And so here we have an article, will the public's health fall victim to the home foreclosure epidemic, right? And you'll notice something, it says on the very top left, essay, which means this is not a research study, this is a conversation piece, a perspective piece, trying to answer this question. Because from a research standpoint, what kind of data would you get to answer this question? Right? This is a very, very difficult question to answer. What is the health impact of the Great Recession? Right? And so the work on this topic picks little things here or there, but it's very hard to get any handle on this. So what we did was we looked at search data. And the search data we have here is from Google Trends, which makes trend data available. And what we did is we looked at queries that were related to health concern. We looked at hundreds of these. And you can see they're all plotted here. And the solid line is the trend. Right? And what you can see from the picture a little bit, and we have lots of numbers showing exactly what happened, is when the recession started, there was a noticeable uptick in these sorts of queries. Right? You can see some specific examples like stomach ulcers and headache symptoms. And what we are able to show is the number of people querying for these health-related concerns increases during the Great Recession, much more so that you'd expect the normal progression to be. Looking back, I think we look back to like 2004 or something like that. All right, I'll get your question in 1 second. So I'm not going into a lot of the details of how you actually do a study, but the point here is this is a question that in public health, it's very hard to get any kind of handle on or any kind of answer. And here is a very straightforward way of using search behavior to try and give some evidence suggesting what's going on. Obviously, this doesn't prove anything one way or another, but it's giving evidence in an area where there would normally be no evidence to speak of. Did you have a question?
What's the y-axis?
The y-axis is it's complicated. It's like normalized query volume.
Oh, because they don't want to.
Yeah, Google does not want to tell you how many users they have, so they do these normalizing things, and to get the data require lots of tricks to make sure everything's on the same scale. And if I had access to your data, I would not have to do any of those things because I would know the real numbers. But there's a lot of tricks in how to do these correctly. But that's what the y-axis is.
Is it some kind of percentage of all the search queries?
It's no.
Because maybe they were just people just started using the internet.
No, it's not the percentage of all search queries. It's normalized for a lot of these things. So if you've used Google Trends, they do a lot of normalization to try and account for this, and so it's more of they actually do like a per query normalization when they give you the results to show you how this query has trended over time, and that counts a lot of this stuff. And then in order to get those to be comparable denominators requires some tricks about how you download the data. Yeah, these are all good questions, and the answers are actually like really long, complicated, and it's really based on the interface Google has. If you had access to the raw data, you could do a lot of this yourself, where you could just directly account for things like new internet usage and where and et cetera. Okay, yeah.
So has it come back down?
You know, that's a good question. This plot cuts off in 2011, and that's based on when we were the period we were focusing on. I don't remember what it does after that. I should also say on this topic, my colleagues have a lot more papers about specific things like the effect of like the S&P 500, the effect of foreclosures, and they actually go into showing which kind of financial situations have the more of an impact on health. This is just the study I'm showing you is a very broad kind of analysis. Okay, so another example, Mondays. How many people have heard of the Monday effect in medicine? Okay, one, good. So it means a lot of different things. So if you ever can choose when you go to the ER, don't go on Mondays. Mondays are some of the worst days for going to the ER. There's a lot of theories as to why this is. But in general, a lot of areas of medicine, there's a Monday effect where things seem to be more pronounced on Monday, right? And here are some papers looking at very specific areas of medicine where that's happening. There's actually a whole nonprofit organization called the Monday Campaigns that is trying to build on this and say Mondays are a day of health. People seem to have more of an interest in health on Mondays. And so let's do health promotion on Mondays. Let's make Monday the day of health. Well, the question is Monday actually a day of health? Meaning, are people more interested in health, more engaged in health, or thinking more about their health on Mondays? Right? And I'm kind of asking, is this worthwhile doing, or should it be the Tuesday campaign, or is there any day? And so again, this is something that we can do with search queries, where we can look at large numbers of queries related to health and see which days they're actually trending on and where we have more. And again, we see this is many queries aggregated by day of week. And you can see that Mondays do have more queries than the other days, almost as many as Tuesdays, almost as many, and it kind of goes down during the course of the week. So I'm not commenting on why this is, and there's a lot of different theories about why these effects exist, but the point is there's another way where there wasn't a lot of evidence on a broad scale about health interest in Mondays until we came along and looked at these sorts of query behaviors. And if you know about how to use these query traffic, this is not a very hard thing to measure. So the last example I want to give is looking at Twitter data. So trying to understand when people are interested in smoking is very important in smoking cessation, right? And so not only day of the week, so for example, it's well known that people are more interested in quitting smoking around New Year's. There's some other days, but New Year's is a big one. So there's a lot of quit smoke campaigns that run right after New Year's because they know there's a lot of interest. But there's interest beyond that, just time of the year. But in general, when are people interested in smoking, and when do people go to get cigarettes, right? So here's an example of a paper. What they did is they collected about 400 people, and they had them journal when they had cravings and when they smoked over 2 weeks, and they aggregated the data. And this is an example of the sorts of studies that people are doing, very small scale, very hard to run. And obviously, it's going to take a lot of work to recruit that number of people to journal at this level. So what we did is something very simple. We looked at tweets, and we just looked for tweets. And how we did it, machine learning, NLP, the details aren't important. We looked for tweets that said, basically, I want to smoke, I want a cigarette, things like that, right? And then we just showed what the day looks like, right? And you can see here, and the trends of what we actually found are not that important, but the point is, it's not that hard to plot these kind of trends to see. This is a 24-hour period of when people are actually saying these sorts of things. And again, this is over now millions of people. So it's a really fast and easy way in order to measure these effects, not over a couple hundred people in a really labor-intensive way, but over a much larger population. And you can imagine doing much more interesting things and much more nuanced things with this data. This is just a really simple example. So those are some examples I wanted to give at a very high level of where I think there are really easy things to do for us that can have a big impact in behavioral medicine and public health. The next phase I wanted to go through was talk about one specific example and some of the methods that we developed for that. Before I went there, are there any questions about the examples I gave? Any? Okay, great.
The previous slide with some baseline.
A baseline meaning?
What if all Twitter traffic follows that exact pattern?
Oh, we normalize for that.
So this is normalized?
Yeah. You have to normalize for that, otherwise you don't get anything interesting. Yeah. Sorry, I'm glossing over a lot of details because I'm trying to give the high-level thing. But yeah, you have to be careful on how you do a lot of this stuff. This is actually a very, very preliminary result. It's not published. Before I actually want to publish this, there's a lot of other work I want to do to follow up on it. And also a lot of questions that I have yet to answer about this. But yes, you have to normalize it. And also we did the time zone shift so that we're not just this is not global GMT time, but it's per time zone, yada, yada. Okay. All right. So I want to talk about drug use. And let me first tell you the data set we're using. So we're not using search data here, we're using forums. And we're using a site called Drugs Forum, and we have about 100,000 messages from the site. And roughly speaking, this is a website where people go to talk about illicit drug use. Okay, so that includes things like cocaine, also alcohol, marijuana. It's really quite a huge diversity of drugs. And what we're interested here is mining people's reports about experiences of using drugs. So why do we want to do that? So the landscape of drug use has changed a lot in the past decade. It used to be that new drugs came along very rarely, and they kind of made a big impact when they came. What's happened in the past couple years is we've shifted to this community where this marketplace where there's a lot of new drugs that come out all the time, and only a couple of them make it. And that's primarily because a lot of these are synthetic compounds. So there are labs all around the world churning out new compounds all the time in order to get people high in new and interesting ways. So in 2011, there was an EU report out that there are 49 new drugs that came out that year. So that's about one a week, which might not sound like a lot, but if your job is to figure out what's going on and what these drugs are and who's using them, what they're called, that's a lot of drugs to keep up with. Right? One a year is something more close to what they can actually handle. So this is a landscape that's rapidly changing. Lots of new things are coming online. And when you talk to policymakers or you talk to people who actually do addiction counseling, they're really at a loss of information because they have people coming in talking about drugs that they've never heard of. They don't know what's in these drugs. They don't know what the names. A lot of times these names mean they're synonyms or the same name can refer to different things. And there's a lot of confusion. And if you want to treat people or come up with policy, it's very, very difficult to do so. So kind of a running example is bath salts. How many people have heard of bath salts? Not the kind you put in your bath. Okay, they're completely unrelated. The name is from something else. So bath salts is something that really hit the news, I think, like 2 years ago. Does anyone remember why? If it sounds ridiculous, you're remembering it correctly. Does anyone know why bath salts were in the media a lot? Because people thought they caused cannibalism. They don't. But there was a guy in Florida who tried to eat someone else. I'm a little funny. It was a couple years ago. He tried to like eat someone else, and the original reports were that he was high on bath salts, and that was like what people did on bath salts. That's not true. But in general, there's this idea that bath salts made you feel like superhuman and these weird things. Actually, the Navy, I think it was the Navy, made an educational video for their soldiers about bath salts, and it's really fascinating to watch because they have like an actor pretending to be on bath salts. So this is a drug that's new. It's from 2007, actually, but no one really knew about it in a popular way till about 2012, 2013. Right? And that's a long time. That's a long time of people using it and it being popular in communities, but not really reaching the level of awareness of policymakers and addiction specialists. And that's because there's so many of these things out there that are coming online, coming on the market. It's very hard to track and keep track of what's going on. So where we come in is we have access to this large data set where people are talking about these things. So in our data set, bath salts first shows up in 2007 with people describing their experiences and giving a lot of information about these drugs. And so researchers are starting to turn to these online resources to learn more about these drugs. And what they're doing is they're just reading messages. And they're just sitting there and reading through as many messages as they can, which is not a very efficient way of doing it. And so what we want to enable is what we call exploratory data analysis. It's probably a term you've heard before, which is a way of using unsupervised learning to organize the data to help people answer questions. And so we're going to rely on topic models to do this. So how many people know what topic models are? Great, because I have Hannah's slides as backup in case people don't. But everyone knows, so I don't have to use your slides. So let me just go on. So let's say we have this data set and we want to apply topic models to this data set. What would we expect topics to be? So a reasonable assumption was topics would be drugs. And in fact, if you run LDA or LDA derived algorithm on this, you get topics as drugs, right? Because people talk about cocaine, or people talk about amphetamines or alcohol or whatever. That sounds great. But we're also interested in the route of how they take these drugs. So we're interested not just in partitioning the data by the drug, but by how people take it. So were they taking it orally, or injecting it, smoking it, snorting it? There's actually like 10 different ways to take drugs. If you can think of the other 6, I'll give you extra credit, but I don't want to discuss them in public. But we're also interested in the aspect. So people talk about the chemistry, so what's in a drug. They talk about the cultural context of drugs, the effects they have, the health impacts they have, how you use it. These are all ways of dividing up the data we care about. And we're interested in unsupervised learning because we just have this massive data and we kind of want to throw it at an algorithm and let it discover these things. And so a topic model is only so useful because a topic model will essentially pick out one of these divisions, but not all of the divisions. So we realize this is a problem that's more general. So if you look at this is a product review with speakers. The topic here is speakers, but there are other things that are impacting this review besides the fact that it's about a topic of speakers. For example, the sentiment. And the sentiment is going to impact the word use in this as well, right? If I looked at journal articles, right? So here are 2 papers. They're both about clinical natural language processing, but this one is from a medical journal, and this one is from a computer science conference. And so not only do they get formatted differently, but they actually look different. They speak in different ways. And so even though the topic is the same, the venue makes a big impact on the presentation. These are all things that we want to capture, different dimensions of the data we want to capture, and topic models are really going to capture one, or the most prominent one, which is topic. So our goal is to jointly model multiple factors of text. We want to consider not just one of these things, but multiple things along these lines at the same time. So let me explain to you how we do this. So this is how we generate documents under a simple topic model like LDA. Right? So each document will have a distribution over topics. From that distribution, we're going to pick a specific topic, and here I'm going to use topics that you might see in a machine learning NLP conference, like speech. Speech is now back in vogue at NIPS, for those of you who are there. And it's not new, it's like the past 2 or 3 years. And then, actually thanks to Microsoft in part, but, and then from that topic speech, I have a distribution of words. I'm going to pick one word for my document, and I'm going to repeat this multiple times by picking another topic, another word, all right? So what we want to do is augment this to not only consider the topic, but let's call it, for the sake of argument, the approach of the paper. Is this a theoretical paper, or is it an empirical paper, all right? And so now, I don't want to have a distribution over topics. I want to have a distribution over these factors, right? So the factors being the topic and the approach together. And my distribution is not going to just be the topic, but it's going to be the theoretical speech topic or the empirical speech topic. And from that topic, I'm going to draw a word in my document. So far, so good?
Is it a joint distribution?
This is going to be, yeah, there's going to be a distribution over these tuples.
So why isn't that equivalent to just having a number of topics equal to topics times approaches?
That's a great question. So a couple of reasons, and they have to do with the structure of the model. So let me present the model, and then we'll talk about it. Aside from the fact that you actually don't get the kind of results we do if you just increase the number of topics. So the baselines we run against are if you increase the topics so that they match the number of tuples, and the answer is the model has the power to learn it, but it doesn't actually learn any of those things. And you'll see why when I talk about the structures. Great question. Everyone at the NIPS poster asked me that question too. Okay, so let's look at LDA as having a vector where the vector corresponds to topics, right? So here's my vector. I'm going to have theta as a distribution over this vector, right? So theta itself is a vector. And every position in this vector is going to correspond to a distribution over the vocabulary, which is phi, right? So I have a vector of length k, and I have k phi's associated with that. So in the multi-dimensional case, and here I'm just going to show you 2 dimensions, but this extends to n dimensions. You can't make n that big if you want to learn, but 5, 6 we've done, no problem. We're going to have the topics now in a matrix, but we're also going to have what we'll call the approach, the theory or empirical. And so now theta is a distribution over this whole matrix, right? So it's the probability of picking theory information retrieval or empirical MT. And every one of these cells now has a distribution over the vocabulary associated with it. So there's a distribution for information retrieval empirical and another distribution for speech theory. Okay? And now I have essentially what I set out for. So now when I want to generate documents, I have my distribution over these tuples, which is the distribution over that matrix. I pick one cell in that matrix to be what's going to generate this word. That indexes a phi, which is distribution of the vocabulary, and I draw from that phi a word in that document. All right? And so now documents are not about speech and maybe a little MT, they're about speech theory and maybe a little MT theory or something like that, or empirical MT. Okay. So if we just did that, it wouldn't work because there's a couple challenges we need to overcome. The first one is similarity across these columns. So I have a phi for every one of these columns, but obviously, and every one of these rows, I have a phi for every cell, but obviously the rows and columns have a relationship, right? The speech theory and speech empirical distributions should look similar because they're both about speech. Similarly, speech theory and MT theory should look similar because they're both about theory. So what in the model is going to encourage this? And this is where you start to see the divergence from LDA, because LDA doesn't have those kind of structures to encourage that behavior. So LDA is going to select every phi from a single Dirichlet distribution. In our case, our multidimensional topic model, every phi is going to be drawn from a Dirichlet that's specially parameterized just for that cell of the matrix. So every cell of the matrix is going to have its own Dirichlet, but all of those Dirichlets will encode the relationship between them. So that way, when I draw a phi for speech theory and a phi for speech empirical, they will be not from the same Dirichlet, but related Dirichlet distributions that ensure that there is some overlap between them, where that overlap is going to be in the speech words. So how do we do that? So we start with a list of speech words, and this is all learned unsupervised, so I'm talking more from a generative process standpoint. We start from a list of speech words and a list of empirical words, and these are words that we expect to show up in speech topics no matter what the approach is, right? And these are words we expect to show up in empirical work no matter the topic. And obviously they're going to, what actually shows up might be different depending on the topic or the approach. Right? But here's kind of words, and you see this is actually examples learned by a model. This looks like speech recognition, and this looks like empirical work. Tasks, performance, improve accuracy. This is your guide to getting a paper in, right? An empirical paper. So each factor has its own weight vector of the vocabulary. When we want to generate a phi for speech and empirical, that tuple, we're going to take these, combine them, and get a new word list, right? That's going to reflect both. Right? And so now you see it's going to mix in speech words and empirical words together. The key is that this is only what our model thinks should be the case, but we want to allow our model to deviate in the data from what it actually thinks. Meaning, given what we know about speech and given what we know about empirical work, this is what we think those documents that are empirical speech look like, but they're of course going to vary in some way. And so we use this as a prior, and we use this as the parameters to the Dirichlet. And we sample from there our actual distribution. And this is the actual distribution you see. So this is the speech empirical distribution. If you know anything about empirical speech work, these words should make sense to you, right? Dialogue systems, speech, tasks, right? And now you see a mixture of the speech topic and a mixture of the empirical approach. So the key is we do this both for the phis, like I've been saying. We also do it for the distribution over tuples for each document. And what that means is a document that's talking about speech theory will be more likely to talk about speech empirical and more likely to talk about other theory than it will than other tuples, right? So when you have one cell that becomes more likely, everything else in that row and everything else in that column also will become more likely in the document. And so that's a way of encouraging related tuples to show up together. All right. The second challenge we have is unsupported tuples. So if you think about it, if you've been thinking, well, you have a whole matrix of these things and you want to go to the third dimension, some things don't make sense, right? So there isn't really, I'm going to make this argument. It's not really necessarily true, but there's no really MT theory, machine translation theory, right? That's a very empirical field. Every paper must show blue score improvements. There's not really a theory behind that. And so it's not really expected to see that we would actually have any documents that show up in the MT theory box. So what we want to allow our model to do is opt out of learning that box. We want our model to say, this cell cannot happen. And so we do this in a very simple way. We have another matrix of the same size that's going to be a binary matrix that will serve as a bit mask. And here the shaded in things, it doesn't really matter which way you want to do it, but one of these is a 1 and one of these is a 0, depending on what you prefer. And so what we do is we take these two matrices, right? We multiply them together in our Dirichlet, and that's where we actually sample our distribution over tuples from. And so what that means is if that bit is off, we can never have that tuple appear. And so now if we want to say there's no such thing as theoretical machine translation, all we do is allow the model to set that bit to be 0, and now there's no data that can ever have that, and we don't have to worry about learning phi's to account for that. So this is one of the details. In practice, if you actually try and do this with the binary matrix, it's very difficult, and we can talk about why it's difficult to learn binary matrices for sampling and the IBP and all this stuff. But if you've tried it, you know it's very difficult to get this to work. So what we do instead is we approximate it with a real valued matrix. So B is actually real valued, but we put a U-shaped beta prior in it. So we want values in that matrix to be as close to 1 or as close to 0 as possible. And this is what we actually get when we learn it. So the prior is the dashed line, and you can see the histogram here is the values we learn. So most values are on, which means our model says, yes, I see this tuple in the data. There's a lot that are off. And this actually is very interesting. There's a small number here. They're not quite off, but close to it. There are very few on the other side of that 0.5 line. And what that basically says is there's a lot of things the model sees where it would like to shut it off and say this tuple can't exist, but it ends up relying on it because it really can't explain the data very well without it. And so that's not a problem. We allow the model to do that, and we actually present it to users. We threshold here, and we only show users tuples that are on the side of the line. And that works very, very well. I really don't want to say much about how we do parameter estimation here because it's really not interesting. It turns out to be not a big change from LDA, where the E step, we're replacing the Dirichlets with these structured parameters, and that's now the same as LDA. And then the M step, you have to learn not only the parameters, which you can do with hyperparameter estimation anyway, but you also have to learn this bit mask, which is not that hard to do. Once you make that approximation. So if you're curious more about this model, we published this a little bit ago at NIPS called Factorial LDA. We have a new paper coming out that generalizes this called Sprite, generalizing, I can't remember what Sprite stands for. It's like structured priors topics. I can't remember the rest of it. But this will be out shortly. And it generalizes this to a lot of other cases that I think are really interesting that I don't have time to talk about. Yeah.
How do you enforce the fact that one dimension is about topic and one dimension is about approach?
Good question.
It could just be some topics here, some different topics here.
Okay, so we'll get into some details about running this. So, the most experiments we've done are completely unsupervised, which means we just take the model and we run it, and all those weight vector lists and all that are completely learned from the data. I'm going to deviate from that in a moment. So as a general guide, when you say to the model, I give you 100 components, we call them, of factors, it uses those to explain the largest, the words that cause the largest variations in the data, which is basically always topic. Every data set we run on, it always learns topic. So what we do is we make the first component like 100 or 200, whatever you normally make topics, and the other components we make very small numbers. And so every data set we get something a little different. For like running it on computer science abstracts, we get something that looks like topics in the first dimension. The second dimension, you see like approach. And then the third one, I'm blanking what it is. It's like the second one's like empirical and theory, and the other one is like something like data versus methods. I'm trying to remember exactly what it was. And we have a name for that. On other data sets, you see other things. So we've run this on like web forums, not related to this, but other web forums. And we get like topics as the first thing and then sentiment as the second thing. So it depends, if you're really running this in a very unsupervised way, you get different things depending on what the data set is. And then you can set the number of parameters you have, the number of dimensions you have. So if you're doing 2-dimensional, 3, 4-dimensional, whatever, you can set that to capture whatever you want. Is that?
Yep.
Okay, good. But the short answer is make one number really big, and that's always topics.
Okay.
That's why topic models, by the way, are topic models and not models of authors or whatever, right? Because they're capturing the largest discriminators in the data, which is topic. Okay. That's why domain adaptation methods work the way they do, et cetera. That's just a thing about language. All right, so let's go back to this. So let me show you some examples of what our model gets. If we think of cocaine storing in health, we get something that looks like this. And even if you've never used cocaine, hopefully, that you can still recognize this as negative consequences of storing cocaine in your health, nosebleeds. If we just change this to usage, we should see things that are only different from the previous one by the fact they now talk about usage instead of health. And you see you get things that are still about snorting cocaine, but now very different. How you snort cocaine, line, small, cut. These are words that some of you may be familiar with.
You don't do stemming?
No, we don't do any stemming. So generally when you do, whenever you talk about topic models, there's a list of things that you can do when you actually want to show this to users. I don't consider you guys users, so I didn't do all those things. But like stemming and stop words and all these sorts of things. Okay. So one just small note on the training here to explain this. So here we're treating the drugs as supervised, and that's because the way the data is structured, every post belongs to a forum, so we know what the topic is, and we know what the drug is. So we just say, well, that's supervised. The other ones, we derive priors automatically from the data, and I'm not really going to talk about that because there's a whole other learning step. But we have a lot of different applications of this model where we use supervision in different ways, and sometimes it's completely unsupervised, sometimes it has complete supervision like here, sometimes we use automatically derived priors, sometimes we use manual priors, and it's very, very flexible and allows you to do lots of different things depending on your data. So how do we actually use this, right? So does it work for the case we care about? So I started by telling you there are people we work with in the Department of Behavioral, I can't remember the whole name of the department, but it's the one that has all the drug use researchers. It's a complicated name. And they want to use this model. So how do they want to use the model? So they have questions about like how are people using salvia? And so the way we answer it is we say, well, let's take this tuple, salvia smoking usage. Let's find the sentence that is the most representative of that tuple and show it to the user. Right, here's another example, salvia oral usage. This is the most representative sentence. And you can see this is clearly about how to take salvia, how to use it by pills, and this is how to use it by smoking it, right? And so what we did was we showed this to users, and we showed them alongside these excerpts technical report descriptions that actually, based on research, answer these questions. And we showed them a lot of these sentences from different baseline models, and we said which sentence best answers this question, and they picked our sentences more than the other sentences. That's my high-level summary of our results. And in addition to the quantitative result, those sorts of quantitative results, we've done a lot of qualitative studies showing these to our colleagues who think this is really great and they love it. Right? So this is just one example of how you might use a model like this. Any questions about this? Okay. So the last thing I want to do is tell you a little bit about what I'm thinking about doing next and where I'm going. And let's go back to these fundamental questions in behavioral medicine. Right? How do people make decisions? How do people weigh evidence? And what are the different factors socially that impact how people make those decisions? And I've been brainstorming what I can do with data that I don't normally have access to. So you've heard a lot of examples with data I have access to, but you guys have data I don't have access to. So I thought, what would it be like to have the access you guys have? And that might be like search sessions, which I can't get, or it might be things like browsing behavior or much more social data. You guys have data sets I'm not even thinking of, mobile, right? What are some interesting things to tackle? And I'll just give you two quick examples. The first one is vaccines. So vaccines are really interesting because vaccines are an area of research where we've basically cured a disease, right? We have a vaccine for smallpox. If you take the vaccine, you basically don't get smallpox. I'm glossing over how vaccines work a little bit, right? This is phenomenal. But we have an epidemic of sorts in the immunization community because of the anti-vaccine movement, right? Where people are, for a variety of reasons, not taking this. There's your money again, by the way. So this is obviously a big problem. And for those of you following this, this year has been a resurgence of things like measles and mumps in the United States. It's also a resurgence of polio in Syria for other reasons, because people are not vaccinated. So there have been studies on how we can try and make people vaccinate, right? And so what they do is they sit people down and they educate them in a variety of ways. It's a randomized controlled trial, so they try different educational approaches to try and increase their awareness of vaccines. And you guys will probably be familiar with this sort of result. The studies show that at the end of these interventions, the people have less misperceptions about vaccines. They're more informed, and they demonstrate and test that they're more informed about how they work, but they are less likely to get vaccinated. Okay? People have seen results like this before? No? This is not this is a very common sort of result in like political science and such, where you educate people and they seem to be more educated, but they're more convinced fundamentally, like their actions betray that education. And their actions suggest they're even more committed to their mistaken beliefs. This is incredibly depressing because this represents exactly what we're trying to do in terms of educating people. This is how we're educating people. People are becoming more educated about the benefits of vaccines and are less likely to use them. That's terrible, right? So this really goes at a lot of those core questions, like how people weigh information, how people make decisions, how people's social information influences that. And we really need to understand these things in the context of vaccines if we want to do anything about trying to increase their usage. And this is, I think, a lot of this is beyond the sort of data I have access to. I think looking at the sort of people, the sort of search sessions people have over time, what sort of websites they visit, how they browse the internet, the sort of social interactions they can have, you really can try and answer some of these questions. And really, when you look at the demographics, I think is key. Because it's not just the fact that everyone believes something about vaccines, but the misperceptions vary tremendously by different demographic groups, right? So vaccine refusal is high in kind of like suburban LA upper middle class families and inner city, right? For very different reasons, right? And so you don't want to just throw data at this. You want to throw data at this where you understand the demographics, and I don't have access to those sorts of search, right? So I can look at search trends, but I can't do anything with demographics because I don't know anything about who these people are. It's all aggregated. So I think you can do tremendous value here in learning about the population. And I also think, and we can talk about this later, there are possibilities for interventions as well, right? Trying to run a study like I just showed you on a much larger population where you target messages to different demographic groups and see what the impact is and if it actually changes their behavior. One other quick example I'll give from tobacco control. Electronic cigarettes. How many people have heard of electronic cigarettes? Okay, this is big. How many people have learned about them in like the past year or two? Okay, so this is like the biggest change in the tobacco world in the past 10 years. Every time I go talk to tobacco control people, this is what they're thinking about. To them, it's huge, all right? As a result, there's been a lot of pressure put on the FDA by states and tobacco control experts to regulate electronic cigarettes, which are currently completely unregulated. And the FDA has said we are willing to regulate them and we're interested in regulating them, but they have a problem, which is they don't really know much about them. So I'll give you a really simple example. One of the things the FDA wants to do is test the contents of electronic cigarette cartons to see what's in them. And they have a really simple problem. They don't know what to test. They want to test what people are using. They have no idea what people are using. Should they go down to CVS? Well, CVS doesn't sell them anymore, right? Should they go down to Rite Aid, pick on Rite Aid, and buy blue? Do a lot of people use blue? They don't know. And so what they're doing is, please don't laugh, what they're doing is they're paying people to go to stores and write down what they see, right? And they're going to use that as a measure to figure out what the most popular cigarettes are, e-cigarettes are. Now that's crazy, and we have papers that are hopefully coming out soon that show you can do this by looking at search traffic and see what people are querying for, and that's a much cheaper and easier way to figure out what my popular brands might be. But another question they have is, why do people use cigarettes, electronic cigarettes? And answering that question makes a big impact in how you regulate them. So we did something really simple. We looked at Twitter data, and this is actually all manual coded, but you can automate this. And we looked at the reasons people wrote in Twitter about why they were using electronic cigarettes, right? And so quitting smoking is the single most popular reason, and this is how they're typically advertised, right? And you can understand why they might be advertised that way. But supporting smoking is also really popular, almost as popular. And supporting smoking basically means I want to go out with my friends, but I want to smoke. New York City bars don't allow me to smoke. Thank God there's e-cigarettes. I can keep smoking inside the bar, and that way I can support my habit. That's very, very, very bad, right? These other things aren't so good. Like, they make me look cool. I like the flavors. They're cheaper. These are reasons that are more promotion of cigarette use than quitting, right? And so they want to know things like, why are people using them? How are people using these? Are these a gateway drug? Do teenagers start by using electronic cigarettes and move to tobacco, right? They don't know these questions. They don't know the answers to these things. And again, I think these are questions that the data that you guys have here can shed light on. And these are active questions the FDA has, where if they had the answer, they would actually change regulation policy as a result. I'm sure you guys can think of other things that I can't think about, and I'd love to know what those are, because again, you guys have access to data and ideas that I just don't have access to. But that's some ideas where I'm thinking about going. Thank you very much. Thank you to all the people who helped out with this. There's a lot of work here from a lot of different people, and I'm happy to take whatever questions you guys have. Did I exhaust your questions, or exhaust you?
So it seems like you're thinking about public health in that initial two-phase approach, where there's sort of like surveillance and there's action,
Yeah.
back and forth. But I guess to me, it seems like a lot of behavior problems are almost certainly very personal.
Mm-hmm.
And so it's not like a surveillance approach will work. It's more like you need to figure out how to intervene with each individual person so
Yes.
you get the right behavior.
So that's exactly why I said the demographics are key to vaccines. So so take vaccines, right? The typical way they learn about why people refuse vaccines is they do phone surveys, right? So phone surveys are a very expensive and coarse way of getting at specific groups, right? And the groups you can get at are very limited, right? And this is in political campaigns. We don't have infinite number of funds to throw at surveys, right? Running one of these surveys costs a lot of money. There's some slides I took out which had on gun violence, because I didn't have time, and they had one result that we were able to replicate. That result cost them about $250,000, right? Because they have to run these surveys, right? So they don't think that much about the questions that you just asked because they can't get that data. But when you look at web data, you absolutely can look at that data. So I have another version of that last chart I showed you of why people are using cigarettes, broken down by gender, right? And we want to break it down by demographic group, right? I think that's key to addressing a lot of these issues, and it's just completely beyond the resources and the ability of traditional public health. That's part of the reason I'm really excited here, is because now you can do things with this data that you couldn't do otherwise. And specifically, I think it's not that you can do them better, but in the case of vaccines, I think you can actually do something productive and effective that in the current regime you can't even do. So I completely agree. But it's not that they don't know it, it's more they just don't have the resources to do it.
I think it's becoming, so obviously saying that the data is there to do it, but in some ways the data is not there. Because if you really want to get at the causality of things, you need to be...
Right.
You need to be actually intervening, right?
Yeah. So
that means you need to be gathering the data in the process of trying to figure out what to do.
Right. So I'm still at the phase of how much can we do in a very passive way. Yeah. So if you noticed, every example I gave is passive surveillance. There are actually people doing active surveillance too, and not me, and we can talk about that as well. I think there's so much to do in just kind of this passive surveillance that I haven't even gotten to the kind of the active stuff. But I think when it comes down to things like vaccine, I think we do want to do interventions, right? So just think about it like this: computational advertising, which is something everyone here is familiar with. When I talk to people in tobacco control, that's a revolutionary idea. Not the idea that you do advertising online, but that you customize things to people, right? So the CDC ran the TIPS campaign. You probably saw this 2 years ago, where former smokers did television commercials, and they often had visible physical implications because they were smokers. And the whole idea was it would scare people, right? And those are sorts of things. If you look at the diversity of those messages, different messages will resonate with different groups, right? That's kind of obvious to anyone who does advertising. And when you do online advertising, that's what you bank on. That's not even on their radar yet, right? So I think that's why I said we have an opportunity, because there's these things that we do that we're like, of course that's what you would do. And in that community, it would make such a big impact because they aren't even thinking about it yet. And in fairness to them, they can't easily do it even if they want to. Although they did spend, I think, $200 million on tips. So they had some money. Maybe not a lot. Maybe $200 million is not a lot to people in this room. Anything else? Okay.
Okay,
I'm over the time, so I should stop. Thank you, guys.
thank you.